Good morning, everyone. Welcome to the Health for the World International Grand Rounds. Our Grand Rounds speaker today is Dr. Edward Smitaman. Dr. Smitaman is an associate professor of radiology at University of California, San Diego. Dr. Smitaman is a musculoskeletal radiology expert who's a clinical educator and is well renowned for his education. The topic today he'll be talking about is approach to bone tumors. Thank you so much, Dr. Smitaman, for doing this for us, and you can start whenever you are ready.
Thank you very much. And just before we get started, just want to say hello and just a shameless plug for my Instagram account. This is X-rated. This is where I share cases, radiology cases. I try to post daily with followed by some references and answers. So please, if you have an Instagram account, please check it out. So today we'll be talking about an approach to bone tumors. And as we know, diagnostic imaging plays a central role in staging patients with suspected osseous tumors. And hopefully by the end of this talk and our brief time together, we'll be comfortable with when we're faced with some of these bone tumors, as you can see on this this panel above here. And sorry if I drift away or my mic cuts out, please just let me know, and do my best. Okay. I have no disclosures. So as I mentioned, today we'll be discussing musculoskeletal tumors, emphasizing tumors of bone, obviously a broad category, but it encompasses benign and malignant neoplasms, reactive focal abnormalities, metabolic abnormalities, and other tumor-like conditions. We will review the basic evaluation of a bone tumor, particularly the importance of analyzing its radiographic appearances, rather than memorizing long lists, but it does help to memorize some lists in some site-specific locations, and we'll also go over that too. And I'll wrap up this briefly by discussing staging and biopsy, but that in of itself can be another talk that we can work on together. And again, hopefully by the end of the talk, we'll be more comfortable faced with presented with a bone tumor and its workup. So a patient may seek treatment for a bone lesion because it is painful, associated with a palpable mass or pathologic fracture, or discovered incidentally by imaging. In any of these situations, okay, the initial objective of imaging is confirmation of the neoplasm, or to find an alternative explanation for the patient's symptoms, such as trauma or infection. But once we confirm that a tumor is present, an assessment of its characteristics, that is, its morphology, okay, provides important information regarding the aggressiveness or non-aggressive behavior of this lesion. This helps to predict, but does not necessarily equate with malignancy or benignity. For instance, we all know that infection, although a benign process, can look quite aggressive. That said, after establishing the aggressiveness or risk of malignancy, combined with information related to the site of skeletal involvement, sprinkle in some information on patient demographics and perhaps other techniques, and possible tissue sampling, allows the formulation of a single diagnosis or a concise differential for most bone tumors in any patient. Now, as we know, imaging plays an important role in the evaluation and treatment plan of patients with musculoskeletal tumors. And these tumors can often be accurately characterized using appropriate imaging examinations. We know that several different imaging examinations may be used in the evaluation of a suspected neoplasm, but each modality provides a unique advantage and disadvantage, as I've shown here, adapted from a table by Caracciello and Letzen. Radiographs should be the first line imaging, okay? Not only is it cheap, but the differential diagnosis of most bone tumors is generated based on features detected by radiographs. Certain features will suggest either benignity or malignancy and help decide whether additional examination should be performed. Other modalities include MRI, which provides excellent soft tissue contrast, demonstrates marrow edema very well, and lesions including skip metastasis, which is important for obviously the prognosis of any bone tumor. While CT, as we know, allows a better appreciation of tumor mineralization, cortical bone involvement, and pathologic fractures. Excuse me. So let us start the workup of a potential bone tumor by first discussing its morphology. So let's say we found a bone lesion. The next question, as one of my mentors used to teach me, Dr. Katz from Yale, what is the tempo of the lesion, Eddie? That's the next question he would ask me. What is the tempo? Or that is, how aggressive or non-aggressive do we think the lesion is, okay? Is it slow and chill? And I like music, and I love Bob Marley, so is it slow and chill, like a Bob Marley song with an average beats per minute around 75 beats per minute, or does it clock in at a faster tempo, say a Red Hot Chili Pepper song, Give It Away, let's say, at about 180, 190 beats per minute, okay? But the characterization of a tumor's tempo or aggressiveness helps to determine its growth rate and risk of malignancy. And this is based on the pattern of a bone destruction, size, sometimes number, cortical involvement, its periosteal reaction, and the presence of a soft tissue mass. These features were originally described using conventional radiographs, but can also be applied to CT. However, please be cautious when applying these same principles to MRI, because the aggressiveness of some benign lesions, such as infection or stress fractures, can be overestimated as a result of marrow and or surrounding soft tissue edema. So before we discuss patterns of bone destruction, just a quick tangent, okay? Radiographs are not sensitive in the detection of small amounts of bone destruction, especially if the focus is located in cancellous or intramedullary bone. Cortical lesions are detected more readily than are those in cancellous or intramedullary bone, and that's understandable and likely related to the contrast between compact bone and soft tissue. In fact, it has been shown that lytic lesions are often undetectable until the tumor has resulted in about 30 to 50% loss of mineralization. So if your radiograph is normal, as in the case on our right here, and the patient has persistent symptoms, do not hesitate. If available, please consider obtaining MRI, which is more sensitive for marrow lesions, as in this case with prostate metastasis, particularly involving the distal femur here. On this T1 weighted sequence, we can see this marrow replacement. Excuse me. Now, in many cases, the radiographic appearance of a bone lesion provides sufficient information regarding its aggressiveness and risk of malignancy. Lesion margination, or that is the zone of transition, described as narrow or wide, correlates with the rate of growth and thus aggressiveness, okay? This important radiographic feature forms the basis of the widely used grading system of lytic bone lesions, which can be described as geographic grade 1, non-geographic grade 2, all the ways to grade 3, as we can see here. Grade 1 lesions can be further subclassified, by the way, into grade 1A through 1C lesions. Geographic lesions demonstrate a clear delineation between involved and uninvolved bone, and the margins are generally well defined with a sclerotic rim in 1A lesions, as we can see here on the left. Well-defined, and 1B lesions typically will have a well-defined lesion, okay, without a sclerotic rim. Arguably, this is probably more of a 1B lesion, I apologize. And all the way to ill-defined or wide zone of transition with 1C lesions. Now, grade 2 or 3 lesions are typically non-geographic here. That is, these moth-eaten permeative bone lesions when we use our descriptors. But simply speaking, if you take in your mind's eye a crayon or a pencil, and you're asked to draw the lesion margin, you can see here that you could not draw a discrete boundary, okay, or demarcated boundary or boundary around these two lesions, okay. Here with the moth-eaten permeative lesions, that is grade 2 and grade 3 lesions, okay? So these increasing grades correlate with increased growth rates and aggressiveness, so that grade 1A lesions are largely benign, as you can figure. 1B lesions are typically indeterminate with a moderate risk of malignancy, and 1C lesions or higher are considered malignant until proven otherwise. So radiographs of most lesions permit determination of growth rate in a single frame in time and are helpful in deciding which lesions deserve further workup or which may be safely followed. But there are some caveats, and we'll touch upon those in a moment. Here are some examples of geographic and non-geographic lesions. Lesions with aggressive characteristics are often malignant, but certain benign entities, and I emphasize osteomyelitis, other things, LCH or EG, can also appear aggressive. Aggressive appearing benign entities may be associated with additional radiographic or clinical features that will support the diagnosis of a non-malignant lesion. For example, an aggressive appearing lesion with a bony sequestrum in an IV drug abuser likely represents osteomyelitis. But if there's no other such additional information to support benignity, then an aggressive appearing lesion should be considered malignant and proven otherwise, and it should be further worked up. In general, primary malignant tumors of bone are larger, grow faster than benign tumors. However, exceptions to this rule are encountered. For instance, note the case of fibrous dysplasia in the bottom left here, involving a decent amount of the skull. The size of a lesion can also be a clue to its diagnosis. In fact, some entities have a size criteria. For example, osteoid osteoma and osteoblastoma are histologically similar lesions but differ in size. The nidus of an osteoid osteoma is typically less than 1.5 centimeters in diameter, while an osteoblastoma is larger than 1.5 centimeters. Traditionally, a well-defined lytic lesion in the cortex of a long bone with a sclerotic rim has been termed a fibrous cortical defect, okay, if it's less than 3 centimeters in length, and a non-ossifying fibroma if it is larger than 3 centimeters. But some, if you're a lumper, can simply use the term fibroxanthoma for both of these lesions and move on with your lives. So just know, just talk to your clinician and just speak the same language with our referring clinical colleagues. Primary bone tumors are solitary occurrences, okay, while other abnormalities may be multiple. As we know, the most common causes of multiple lucencies in someone older than 40 years of age are Mets, myeloma, and lymphoma. But benign entities such as brown tumors, as in this case here, may look similar and are important to remember in the differential diagnosis. And we can see here this expansile lesion, okay, of the spinous process here, and additional multiple lytic lesions of the vertebral bodies, but I'll also note or highlight the atrophic kidneys here, indicating end-stage renal disease, in this case of osteofibrosis cystica, or secondary hyperparathyroidism renal osteodystrophy that we see often in hemodialysis patients. Another radiographic feature that provides information on aggressiveness is cortical involvement. Rapidly growing lesions may lead to thinning of bone, and such a bone may be at risk for pathologic fracture. Although there is no perfect method for estimating risk fracture that I'm aware of, I provide the often used Merrill's classification on your right here. But basically what we can extrapolate from this table is the more destruction, particularly of weight-bearing bones, are at higher risk of pathologic fracture. But granted, obviously, patient activity may impact this risk as well. Moving on to more morphology, okay, periosteal reaction. This may be described as solid, most benign in most benign etiologies, okay, as we can see here, to a hair-on end or sunburst pattern, okay, in spiculated and malignant diseases. Solid periosteal reaction is a non-aggressive appearance. It indicates that the underlying lesion is slow tempo, giving the bone a chance to wall it off. A multilamellated or onion skin appearance, okay, suggests an intermediate process. one that waxes and wanes, or one that the bone is continually trying to wall off but cannot. A hair on end or sunburst pattern, the most aggressive appearances, are highly suggestive of malignancy. But remember, sometimes periosteal reaction can occur as a result of pathologic fracture through a benign tumor or a benign lesion, okay, and not because of the aggressiveness of the tumor itself, as can be seen with, let's say, simple bone cysts in the proximal humerus. Now, the presence of a soft tissue component suggests a malignant process, okay, as we can see here. The tumor may have destroyed the cortex as it is expanded, or it may have permeated through the Haversian canals to reach the surrounding tissue and may displace adjacent fat planes. Tumors that often have a soft tissue component are osteosarcoma, Ewing's, and lymphoma. So, and especially Ewing's, okay, that's an important one to keep in mind. So, to wrap up briefly, okay, or to summarize briefly, non-aggressive characteristics include a narrow zone of transition between the lesion and the surrounding normal bone, an intact cortex, solid periosteal reaction, and lack of a soft tissue mass. While on the other side of the spectrum, an aggressive bone lesion includes a wide zone of transition, cortical destruction, that sunburst or hair on end periosteal reaction, and an associated soft tissue mass. So, following the assessment of or tempo or aggressiveness of a bone lesion, a specific histologic diagnosis or concise differential can be made for most bone neoplasms by evaluating the internal matrix or composition of a mass. Demographic information such as age and gender and site of disease, which will follow or we'll talk about next, also contributes to the construction of that differential diagnosis. But want to just highlight, okay, that internal matrix of a bone lesion is best evaluated at by radiography or CT and points to the cell lineage. But remember that the term matrix refers to the type of tumor tissue, such as osteoid, as we can see here, chondroid, or fibrous, okay? Tumor cells are all radiolucent, okay? And mineralization refers to the calcification of the matrix that the tumor cells produce. This concept of matrix mineralization is important to understand because the pattern of mineralization can be a clue to that type of underlying matrix and thus the diagnosis. For example, on the left here, bone-forming tumors that are fluffy, sort of amorphous and cloud-like, if you will, okay, cause an opaque radiographic appearance. Calcification of chondroid tissue is classically been described as rings and arc or even popcorn-like, okay, indicating that the lesion is cartilaginous, as in this enchondroma here of the proximal humerus. And ground glass mineralization indicates fibrous tissue, and this is an image that I've taken of a piece of or a window that was obscured after a shower, okay, and we can see here that mineralization, but as we know, mineralization can be faint and is better probably assessed by CT, which is more sensitive than radiographs for attenuation differences. So, but within and or around a lesion, trabeculations may be identified, which reflect either modified or displaced residual trabecula affected by tumor, or in some cases represent new bone formation as a response to the neoplasm. Thus, the location and appearance of trabeculation may provide useful information regarding the nature of a neoplasm. For example, a hemangioma in a vertebral body will have the classic vertically oriented, coarsened, corduroy, or polka dot appearance on longitudinal, okay, and axial images respectively. With ABCs, for instance, it's typically these delicate horizontally described trabecula have typically been described with such expansile lesions. So now that we've reviewed morphology, time to combine some information related to the site of disease. However, it would be correct to start the assessment of a bone lesion just with knowledge of location and patient demographics. There are many ways to approach a bone tumor, that is to skin a cat, as they say, but knowledge of location is enough to narrow the differential diagnosis without even looking at images. Okay, so let's go over some of those sites and distributions. Now, most bone tumors regardless of whether they are benign or malignant, often occur in a characteristic location that is axial or appendicular, as we can see in our schematic here, okay? Some tumors, such as osteosarcoma, okay, have a predilection for sites of rapid bone growth, usually in the metaphyseal region about the knee, as we can see here. Other tumors, because of their derivation, predominate in one or more areas of the skeleton. For instance, chordomas, which like to develop from notochordal remnants, it is thought, of the primitive notochord, and are typically seen at the central the cranial and caudal limits, okay, of the vertebral column. A lesion in a long bone, okay, let's extrapolate further, may be characterized by its longitudinal location, that is epiphyseal, metaphyseal, or diaphyseal. And these lesions, as you can see, can be further divided by the patient's age. And don't worry, if anyone would like, I'm happy to provide PDFs of this talk. Just please send me an email so you don't have to rush jotting notes. Furthermore, okay, moving on, the lesion in a long bone can be characterized by its transverse location, okay, that is central, eccentric, cortically based, or juxtacortical. And we know, for example, simple bone cysts and non-ossing fibromas are both metaphyseal lesions, but simple bone cysts are typically central or medullary, okay, while non-ossifying fibromas or fibroxanthomas, whichever term you use, tends to be cortical, and I've listed some examples here, as you can see at the bottom. Now, adding some patient demographics or information on patient demographics can support or further limit the diagnostic choices for a lesion. But I want to remind us that our concept of disease should match the demographics of your patient population, okay? If you serve, let's say, a low or middle income community, you want to add things like TB, okay, or tuberculosis for these spine lesions, as we can see here. But if you work, let's say, in the southwestern United States or perhaps Latin America, you want to think of things like cocci or cocciomycosis, okay? This turned out to obviously be infection of the spine. Here, just to harp on patient demographics, two similar lesions but different ages. If the patient is young, as in our left here, think of a primary bone tumor. In this case, turned out to be an osteosarcoma. Okay, on our right, an adult over 40 typically. This lesion much more likely to be metastatic carcinoma, myeloma, or lymphoma rather than a primary bone sarcoma. And this lesion, as we see here at the left hip, turned out to be thyroid metastasis. A lytic lesion in the epiphysis of a long bone of an adolescent is more likely to be chondroblastoma, whereas the lytic lesion in a long bone of an adult is more likely to be, say, giant cell tumor, or one would even think of subchondral cysts and geodes related to degenerative changes. So the incidence of certain tumors varies dramatically with a patient's age, and I share some of those in the classic format that we can find in the literature, as we can see here, and we've divided as above 40, 0 to 10 years of age, 20 to 40, and 10 to 20 years of age. And again, don't worry, I am happy to provide PDFs of my talk. But please remember, okay, in older patients, typically anyone above 40 years of age, 45 to 50, even a non-aggressive appearing lesion, as we can see here, this arguably a 1B lesion-ish, okay, 1B-ish lesion, are malignant, are likely to be malignant, okay, and this turned out to be a lung metastasis, okay. So briefly, just to summarize just to add some general words, metastatic disease is typically the most common bone tumor. And we're going to use bone scan to look for multiple foci, and we're going to use CT and mammo to look for the primary. But also, we're going to look for the most accessible lesion for biopsy planning as well. Okay, most common primary malignancy of bone is going to be myeloma. Okay, typically in older patients, osteosarcoma, and followed by Ewing sarcoma. The peak age. Unfortunately, for primary bone tumors, are young patients, typically 10 to 30 years of age, but fortunately, benign tumors are more common than malignant tumors. And as I mentioned before, when you're presented with a bone lesion, anybody in about 40 years of age, you want to think metastasis, which is about 50 times more common than a primary bone sarcoma, and work it up appropriately. So some processes, as I've mentioned, have a predilection for a particular bone location, for a particular bone and location. And here I'll just share some of these now, using working our way from an axial to an appendicular location. Okay, as you can see, and I provide some memory tools for those that love or like memory tools. So starting more axially, obviously, at the vertebral bodies, if we're presented with a vertebral body lesion, the mnemonic or the mnemonic I've learned over the years is GO-APE, or that is giant cell tumor, osteoblastoma, ABC, Paget's, and EG. Okay, notice here the osteoblastoma looks similar to osteoid osteoma, but remember that size cutoff. ABCs, you can have, notice the expansile lesion and fluid levels, but please remember, fluid levels is just a radiologic finding or anatomic gross finding, okay? There's a differential for fluid levels. Paget's disease, you notice the coarsened picture frame appearance, notice the coarsened bone, okay, the bony expansion, okay, and the coarsened trabecula. And EG here can present with vertebral plana, but vertebral plana, just to remind us, okay, is kind of like fluid levels with vertebral plana, that is flattened vertebra. This is a radiographic or a gross finding, if you will, and there is also a differential diagnosis for this finding, okay. Moving to sacral lesions, the memory tool you can use here is CAN, or that is chondrosarcoma chordoma, okay, ABC, and neurofibromatosis. Chondrosarcoma loves to involve the pelvis of adults, okay, it's usually a large lesion in the pelvis of adults. ABCs, here again, notice fluid levels, okay, but again, fluid levels is a finding, okay, there's a differential for that, which also includes telangiectatic osteosarcoma. And neurofibromatosis, notice the multiple neurofibromas involving the lumbosacral plexus, as we can see here on this MRI. Epiphyseal lesions, okay, we can use the mnemonic CIGS or chondroblast, that is chondroblastoma, infection, giant cell tumor, and subchondral cyst. Notice here, I just want to harp, okay, infection can look quite aggressive. Notice here the sinus tract and in this kid involved with hip infection here, okay. But remember that benign lesions, okay, can also present as a bone tumor, as in this case of a subchondral cyst or geode, whatever terminology you decide to use. But notice here that there's we can infer that there's cartilage loss with this narrowing of the hip joint space, and then we even see a smaller subchondral cyst at the acetabular side of the right hip here. So epiphyseal lesions, CIGS, okay. And finally, just to go back to the chondroblastoma, notice here with chondroblastomas, typically with MR, what we're going to see is a T2 hypointense lesion with robust surrounding marrow edema, classic of chondroblastoma, and it typically occurs in a skeletally immature patient at an epiphysis, or that is an epiphyseal equivalent, okay, location. Diaphyseal lesions, the memory tool we can use here are cement, that is cyst, enchondroma, metastasis, EG, NOF, and TB. And we can see here with unicameral bone cysts or simple bone cysts, the classic fallen fragment sign associated with pathologic fracture. This, but just to remind us, we don't always see this, especially if the lesion, say, presents at the calcaneal body. Here, the enchondroma with the popcorn-like calcified matrix, again, or the rings and arc calcification. But please remember, again, I just want to remind us, infection, as we can see here, can look quite aggressive, but remember to keep certain benign bone lesions on our differential, especially infection in younger kids, okay? How about cortically based lesions? Okay, FOMOs, or fear of missing one. We can that stands for fibrosarcoma, osteomyelitis, metastasis, osteosteoma, and stress fracture, okay? But you notice here that FOMOs can also be used for some of the lesions that cause bony sequestra, as we see here in this case of infection and osteoid osteoma of the hip here. Here, calcaneal lesions, we can use the memory tool BIG, that is bone cyst, intraosseous lipoma, and giant cell tumor, okay? Bone cysts, similar to the ones in the proximal humeral shaft, can also have a fluid level, but typically these won't present with pathologic fracture. Intraosseous lipoma, as we can see here, follows fat signal on all MR sequences, and we can see here the fat suppression, okay, of this lesion on of the calcaneal body here, confirming that there's lipomatous components or macroscopic fat. Okay, typically if there's macroscopic fat, we know with bone lesions we can sleep at night. It's usually going to be benign. Okay, and giant cell tumor here, another example just to reiterate, fluid levels. Okay, is a as a radiologic finding, and there's a differential diagnosis for that, which again includes ABCs and telangiectatic osteosarcomas. Finger lesions moving more distally or acally, okay, then the memory tool we can use here is GEMS, that is glomus tumors, enchondromas, and sarcoidosis, okay. Some people have said, you know, Eddie, how about metastasis? Classically in the books that we mentioned metastasis, yes, we can. You can include that in the differential, particularly with bronchogenic or lung cancers. But if you, when I was talking to my mentor, Dr. Resnick, and what he's found over the years is lung cancer, even though we talk about it a lot in training, it's something pretty rare and typically happens in far advanced disease. But if you have a case, please forward it to me. I would love to add it to this talk. But here we can see our glomus tumors, okay, classically presents with pain, especially with changes in temperature, okay, especially with heat and cold. Enchondromas can present with pathologic fractures, as we can see here, this subtle break in the volar base here of this bone lesion. But I just want to highlight too that enchondromas in acral locations or distal locations typically will not present with this chondroid matrix calcification as we see in this case here. In this case, I think we just got lucky. And anytime you see a lace-like lesion, okay, and multiple lesions of bone, you want to remember sarcoid. And sarcoid is an important differential to remember because whenever sarcoid involves bone, about 90% of those patients will have pulmonary or other manifestations of sarcoid. And unfortunately, when there's bony involvement, that portends a worse diagnosis. So an important diagnosis to remember. Here I highlight some underlying associated disorders with MSK tumors, radiation, Paget's disease, multiple chondromas, neurofibromatosis, fibrous dysplasia, and typically the top, I would say 5 or 6 are important ones to remember, especially if someone presents with increasing pain, for instance, in a patient with osteonecrosis. You want to make sure that they haven't developed a secondary or malignant transformation of an original bone process, such as osteonecrosis or previous radiation. Okay, and it does typically happen years after, but it's an important thing to remember, especially if you have, let's say, a soft tissue lesion that tends to form, or new night pain, for instance. So something to think about when we're presented with a benign lesion that just starts to act a little bit more aggressively clinically, if you will. Here I highlight some bone tumor syndromes, okay, but probably the important ones that you want to know are the top 2 or 3 here. That is enchondromatosis, Olliers disease, and Maffucci's, multiple osteochondromas, and neurofibromatosis. Okay, here, as we can see here on the right-hand image, this is a case of enchondromatosis or enchondroma protuberans. Okay, and it can look quite large, but these osteochondromas can also cause bursitis, and you can also imagine that if you bump these, they can also fracture and present obviously with pain. Okay, so important to remember. Okay, so just to try to wrap up, just some brief words on staging and biopsy, okay? But again, this can be a future talk that I can share, but just to highlight some brief points, okay? So as we know, imaging factors heavily, okay, in staging tumors, okay? And a basic knowledge of bone tumor staging parameters helps to produce a meaningful reports. Now, although different staging systems exist, probably the two most common used in the United States are going to be the MSTS system, that is Musculoskeletal Tumor Society, and the AJCC systems. They are all based on three common components, that is tumor grade, local extent, and the presence of metastasis. And as radiologists, we can help in all three of these components. Local extent and presence of metastasis, obviously by imaging, and tumor grade, obviously by biopsy or obtaining tissue for our patients, clinicians, and pathologists. Okay, so we can really help in the work of bone lesions. Now, I have focused on the AJCC for this talk only because it is slightly more expanded than the ENAKING or the MSTS model, okay? But work with your clinician or surgeon and see what they use and talk that same language, okay? Now, this is a busy slide, I know, okay? But tumor staging, okay, we'll distill it. Basically, it's an assessment of local extent of disease and an evaluation for distant metastatic disease. Because bone and soft tissue sarcomas tend to respect compartmental boundaries, imaging of a primary site of disease should include the entire compartment, visualizing the mass and in its entirety, and detect any intercompartmental skip metastasis, more common in bone tumors such as osteosarcoma, but occasionally seen in soft tissue sarcomas. Local extent of disease directs treatment planning, and attention must be directed to identify neurovascular involvement. Regional lymph node involvement is much less common, okay, in primary bone tumors because and typically musculoskeletal sarcomas are going to cause pulmonary metastasis. But when you have lymph node involvement, which is more common in the rhabdos, alveolars, clear cell carcinomas, epithelioids, and synovial sarcomas, okay, when you do have nodal involvement, that does portend that does lead to a more poorer prognosis, okay? But as a general rule, IV gadolinium administration is of limited value in the evaluation of primary bone tumors because the contrast between tumor and normal marrow is sufficient without it. However, gadolinium can allow one to better identify areas of solid tumor versus necrosis and hemorrhage, which can be important for biopsy planning. Okay, and I've taken that slide and tried to distill it even further and simplify it, okay, here for better understanding. So now you sprinkle in some recent trends or the more recent editions of the AJCC in 2010, but what we can see here, okay, and I've tried to summarize some of the changes as of the 2010 AJCC, but basically it's basically what we've talked about up until this point, right? But and it's understandable, right? Smaller, lower grade, localized extremity tumors that undergo a lot of tumor necrosis are going to be more favorable. Now in 2018, the more recent edition, the 8th edition, okay, the modifications with that are going to be tumors are now described according to primary site, that is appendicular skeleton, spine, and pelvis, okay? And what the AJC, the latest edition of the AJC has also done is the histologic grading has also been taken from a 4-grade system down to a 3-grade, just in order to try to simplify things for our pathologists. To continue on a little bit about local staging, it is important, okay, to know your compartmental anatomy, okay? Fat and areolar tissue and muscle are relatively poor barriers to tumor spread. And certain regions that we've highlighted here from Mark Anderson's paper from a while back, okay, are composed of tissues that are considered completely extracompartmental. So a tumor involving any of these regions, whether it arose there or invaded from an adjacent compartment, is considered extracompartmental. So that will affect the prognosis. Okay, so important to remember. So knowledge of staging parameters out for the diagnosis and management of bone tumors will help generate meaningful reports. But if you're accustomed to producing complete and descriptive reports, then don't worry. But I provide a template here if you would like to use and build upon in your practice, but I adapted this from Dr. Manister's article from a few years back in AJR, okay? But again, I'd be happy to share this slide with a PDF, so don't worry rushing to copy this slide down, please. Okay, now a few final quick words and wrapping up on biopsy. Biopsy ideally should be performed after all imaging modalities, okay, studies that might otherwise become compromised by post-biopsy edema and hemorrhage have been obtained. And it should be attempted only after consultation with orthopedic oncologist or dedicated surgeon who plans to operate on the tumor, because the biopsy tract should be excised with the tumor, especially if you believe in biopsy seeding or seeding of tracts, so that we don't contaminate additional compartments, okay, neurovascular structures or areas that may be used for reconstruction, such as soft tissue and muscle flaps. So biopsy should be actually considered a part of the surgical therapy, because it may determine subsequent surgical approach and may result in devastating consequences if performed improperly. Okay, and it's been found in a seminal paper from JBJS in about circa 1995-96 that errors and complication and changes in course of outcome were about 2 to 12 times greater when the biopsy was done in a referring institution rather than instead of the treatment center, back in 96 or so. And I'd be happy to provide that reference for y'all. And finally, another talk that I have, and I'd be happy to share that, but just briefly, some classic do not touch lesions or pseudotumors. We talked briefly about intraosseous lipomas as here, as in the calcaneus, and notice here the macroscopic fat proven on the fat suppressed sequence. Stress fractures I have mentioned, and notice the robust edema around this fracture along the compressive side of the distal femur here. It can look quite aggressive, but remember, stress fractures can also present quite aggressively, if you will. Myositis ossificans, as we can see here, soft tissue lesion, and as we know, you don't want to biopsy these early because pathologists can unknowingly diagnose these histologically if you decide to biopsy this. As they see mitotic figures, okay, they can misdiagnose these as a bone sarcoma. Particles disease or granuloma disease that we can see with lytic lesions, typically around hardware. Remember, particles disease, okay, basically chronic granulomatous reactions to we as physicians put into people. Cortical desmoids or distal metaphyseal irregularities, whatever term you use, but basically a tug lesion or tenoperiostitis, where bones and ligaments tug upon the bone. It can be cavitary, as in this lesion, or sometimes form bone, okay, or cause bony proliferation. And finally, vascular malformations. Okay, anytime we see a T1 or T2 dark lesion, you want to think of a vascular lesion and give contrast, confirming that it's a vascular lesion before giving before biopsying. Okay, because you can imagine if you biopsy a vascular lesion, patient could be at risk of bleeding on the table, and obviously we don't want that. So vascular lesions of bone or in and around bones, you want to remember that. So take home points, okay, just to wrap up. We should be comfortable when presenting with a bone lesion now, and you want to start out by asking ourselves, okay, what is the aggressive, or what is the tempo of the lesion? Is it a Bob Marley type lesion, slow and chill, or is it more of like a red hot chili pepper or a Coldplay lesion where it's really aggressive looking and it deserves further workup? If you're asked to biopsy, don't be afraid to biopsy, but please consider referral. If you don't do the biopsy, consider referring to the treatment center or talk to your surgeon or the orthopedic oncologist. And briefly, and I can share this talk next time, some pseudotumors, and be wary of some of those do not touch lesions. And here I share some of these references here. And again, I'd be happy to share a PDF of that. And just again, another a shameless plug for for our Instagram cases here that we share at UCSD, X-Ray Ed. Okay, and I try to share a case every day, or at least present a case and share its answer on subsequent days. And I'd just like to thank my mentor and colleague, Minnie Pathria, who helped me to build this talk over the years. And thank you all, and please be well. And here's my email with for any questions, and I'll hang out for a couple minutes if anyone has any questions, comments, or concerns. Thank you very much, and be well.
Thank you so much, Dr. Smitaman, for your excellent talk. We have a question,
Yep.
and the question is, could you talk about fibrosarcoma and histiocytoma fibrous and the presentation?
Well, fibrosarcoma of bone or soft tissue. So that's, some people will first of all use the term undifferentiated pleomorphic sarcoma now, and that obviously those lesions are going to be typically in older patients. Presents with an more aggressive, sometimes permeative appearing bone lesion, but lytic bone lesion. Typically in older adults, and the differential for those are typically to be like, lymphoma, but obviously mets and myeloma are going to be higher in the differential because just of the patient demographics. But again, those terms are kind of used interchangeably now: UPS, MFH, fibrosarcoma of bone. But talk to your pathologist. But here at UCSD, we tend to use the term UPS now, or undifferentiated pleomorphic sarcoma.
Okay, great, thank you. And does anybody else have any questions? So you can either enter it in the Q&A box on the Zoom, or you can raise your hand. Either of those would work. And as Dr. Smitaman said, he also provided his email, and you can email the question after the session if there is something which comes to your mind later. We have today, radiology residents from Muhimbili in Tanzania, from University of Rwanda, but also other countries who have joined us today.
Awesome. Welcome on. Thank you.
I see Aditi from India, and let's see, there are multiple other countries. So if there are any questions, I'll just wait for 30 more seconds. Please feel free to type it in the Q&A box. And if not, then you can email. So I see here, there's a thank you for the lovely talk from Josephine, Dr. Josephine Iwak. Thank you, Dr. Iwak from Kenya. Dr. Maria Matos says thank you. Dr. Enrique Mainero says congratulations, excellent lecture. Dr. Helena Machipia said thank you very much for a wonderful presentation.
No, thank you so much for taking the time to listen to me. It's my pleasure, my honor.
And we have Dr. Hiba Abdujawad, who also says thank you for your excellent talk. All right, and for Dr. Fatima, you're getting a lot of good, excellent talks right now. Okay, Dr. Fatima Ali Omar from Tanzania, from Ohio, thank you for the great presentation. And Dr. Aditi Chaurasia from India says great talk, looking forward to more lectures.
Appreciate it.
Right.
And if anyone has suggestions on talks or would like to hear a specific talk, please email me, and I'm happy to try to dig through my case files, or try to put something together. And if anyone also is interested, I give here in the U.S. we have board reviews, so I don't know the testing methods at each institution. But if anyone just needs to see, loves to see cases, I love sharing. And again, consider following me on our Instagram account as well.
All right, sounds very good. Thank you so much, Dr. Smitaman, and we appreciate you giving this excellent talk for health.
I'll look for the calendar, and hopefully we'll see each other again soon virtually.
Thank you so much. And they're saying, I'm seeing there's some topics which have come up. Dr. Hiba Abdujawad is saying soft tissue tumors and trauma.
Okay.
if those are possible.
Sure. Sure.
Oh,
Not a
right.
problem.
Thank you so much. Really
All
appreciate
right.
it. And
Take
thank you,
care now.
thank you, and thank you
Okay.
everyone for
Be
joining us.
well. Be safe, everyone. Bye.
Merry Christmas, everyone. Take care. Have a
Take
good day. Bye bye.